Thank you very much, Mark, and thanks to the panel. Appreciate your help. I would point out to you that as 5 years ago, more than 5 years ago, 8 years ago, the family medicine program at Mayo Clinic involved the physician dictating his note in the presence of the patient directly into the computer. The patient had an opportunity to correct, in fact, what the physician was dictating. The effect of the dictation was a direct communication with pharmacy so that the patient could go directly from there and pick up their medications. One of the remarkable things about the American healthcare system is that we had some extraordinarily good solutions to these problems, but our ability to scale up to apply them much more broadly is limited. I promise you an opportunity to get your 2 cents in with regard to the future. In listening to these presentations, there were a number of themes that recurred. I'll just remind you of a few of them, not trying to be totally comprehensive, but clearly governance was an issue, and the role of the highest levels of leadership in institutions and members of boards of trustees. Lucian Leape raised the question of a federal agency, a la the FAA, which could do something about quality and safety. And you heard Chris Castles raise the question of whether the National Quality Forum might be an entity which would set some standards for quality of care and measurement of care. Metrics was a key issue in terms of how much was reported, what its value was, how we might go about making it relevant. There was a lot of discussion about extension of the quality and safety initiative to ambulatory environments and to long-term care. A great deal of discussion about culture. Is that something that we can take on directly as opposed to approach it as part of other kinds of things? And the notion of intrinsic physician motivation was raised, which is an interesting concept in terms of how you get work done. Our colleague from the nuclear regulatory agencies talked about peer review, and by that he didn't mean accreditation visits. What he meant was a sustained period in which a group would go into an institution, whether ambulatory or inpatient, and really look at how the work was being done on a day-to-day basis. And you heard from some of the design specialists the necessity to actually look at what's happening as opposed to the paperwork, the things that are filled out as far as accreditation. You heard a great deal about systems engineering, industrial engineering, and its potential for moving forward, and how, in fact, we get the leadership of our healthcare system to acknowledge that they have a great deal to learn from industry. You heard the suggestion that there be top 10 preventable causes that NAM might identify with metrics for those and have some methods for verification of that. And I could go on, but I wanted to just give you a flavor for some of the things that our speakers talked about. What I'd like to hear from you about now is not speeches about particular aspects of the healthcare system, nor necessarily questions about specific aspects of it, but rather your insights, your suggestion as to what in fact could be done to move this agenda. We all agree that we've got a long way to go, that we've had some progress, that we've got to do something further about quality and safety. What can be done, and what can be done by the National Academy of Medicine, what can be done by other entities. So this is an opportunity for you to make some specific recommendations and suggestions which we would try to follow up on. What have you, is there any part of the agenda which I've recapitulated for you, which has particular interest so that you see as being particularly useful? Are there some things that you see as dangerous in terms of approaches to this entity? So the floor is open, and you have a few minutes to raise any of these questions. Please, is that Jerry Filerman?
Yeah.
Yeah.
Ken, Gary Filerman. I'm on the board of the Accrediting Council on Continuing Medical Education. And your opening question to the first panel was, what are the other issues going forward? And then you answered it yourself later. when you when you interviewed patients, one of their core issues was, is my doctor competent, and does the doctor know what he's doing? Those were the words you said. Now, I think that's the next issue. The gap between what we know and what we do. Not what's going on in the 50 largest healthcare systems in the United States, but what is going to have impact on the 4 providers that share an office upstairs at the drugstore, the primary care providers that were mentioned, who work upstairs at the drugstore. They've been up there for 20 years, and that's where most people get their medical care, not in those 50 systems. We don't have to hear more about what works in that organizational environment. If we're going to have value-based care, we've got to find a way to move the issue of professional development into the forefront of the practice setting. We don't know a lot about that. There is efficacy in CME, we know that, but a lot of it is faith-based. And we really need to systematically examine changing provider behavior, raising competence, maintaining competence in the real practice settings across the country. I think that's the next IOM report.
Well, let me just pursue that with you for a moment. Don't leave the microphone, because again, we're talking about some potential studies and some substantive issues. I would take issue with the role of CME. The data shows that if you pre- and post-doc docs from CME programs, they show accumulated knowledge. The same data shows that less than a quarter of them change their practice as a result of CME. So that CME is in fact not shown to be a very potent way to change practice. Secondly, if you talk to doctors about some of these issues, you had a very nice discussion by one of our speakers about the fact that what they say have nothing to do with what they do, and you get false impressions in terms of what it is they know and how they go about doing things. So I want to press you with regard to, if there was a study, what specifically would you want the study to focus on with regard to changing both the knowledge base and/or the attitudes and behaviors of doctors?
In the context of the day, quality of care.
But how would that happen? I mean, what would you be studying?
Well, there's a study design issue that's at the core of what we're talking about, and the first study that you mentioned, the one that shows the high knowledge and low performance outcomes, is cited as about the best thing we have. And people who are the advocates of CME point to that low percentage of assessed change as evidence that it works, but there's HSR and AHRQ, I think, have to address this methodological challenge that I can't answer so quickly. I think the CME industry has been groping with it unsuccessfully for years.
Thank you, Gary. Up here, would you identify yourself?
Yeah, Chuck Murphy from Inova. I think there's the future direction, and again, work being done, but still on the transitions of care, inpatient, outpatient. Medication reconciliation is a simple example that the patient, the family, the receiving doc, the sending doc, and the pharmacy should all know exactly what prescription and non-prescription meds that patient should be taking. And we're not there yet. And again, as that slide earlier showed, there's so much of our care that's outside the acute care setting. And even today, a lot of the talk was about the acute care setting. So as we're going into the bundle worlds, et cetera, how do we really coordinate that care across the transitions? Thank you.
And what's the patient's role in that, as well as the provider and the pharmacist and so forth? That is the whole.
Well, I think there needs to be more information sharing, as if, for instance, by pharmacies where they're not using it as a competitive advantage, but they're participating as a member of the team in sharing that information. If I send a patient home with a list of their medications, I shouldn't have other active medications in a pharmacy out there.
Good, thank you. Please, over here.
Good afternoon. My name is Farhan Bandiali. I'm a Hopkins-trained public health professional who currently works within Medicare. I have two specific recommendations for you. First of all, one of our colleagues, who was just earlier commenting, raised the very real issue of interoperability issues within various EMRs. And this is something that I've been thinking about for some time, and I would like to propose that IOM seriously investigate the feasibility of a universal, open source EMR that belongs to the public and is, designed by the public and healthcare professionals and providers. The second recommendation is, as someone who works within Medicare, I have to commend CMS on their effort to bring about transparency as it relates to various quality metrics. Unfortunately, there is a disconnect, though. Farzad, I guess he's an anomaly in that he actually referred to the website, but unfortunately right now we're not seeing as many consumers going to the Hospital Compare, the Nursing Home, Home Health Compare websites. And I would urge the IOM, given their position, their sort of latitude, to do something to make these websites, these sources of information, available, promote them so that more Americans can get on and make their healthcare decisions based on this data. Thank you.
Thank you very much. Both good suggestions. I could tell you that I had very spirited discussions with David Blumenthal. I believe ONC missed an enormous opportunity to address the issue of interconnectedness of systems. And I think it's going to take a while to recover from that. As I think Mark pointed out, there is a real possibility to try to do that now, but it's a continuing problem. With regard to publishing the data, I chaired the New York State Cardiac Advisory Committee for 12 years. We published data on the hospital's performance for a whole variety of issues, as well as we had data on physician performance. Patients paid very little attention to that. They tended to go where the physician referred them and so forth. But who did pay attention? Hospital trustees, leadership in the institutions that didn't want to be low down on the list when other people were advertising on the Long Island Freeway about the results of cardiac surgery. So I think we need a combination of activities. Consumers are increasingly interested in that data, making it accessible and meaningful, and at the same time educating people that they don't necessarily reflexly go where their doctor says may be important. Please.
Hi, I'm Peggy Binzer. I'm the Executive Director of the Alliance for Quality Improvement and Patient Safety. We are a professional association for patient safety organizations. Patient safety organizations evolved from the IOM report to Error is Human, and our mission is to foster the ability of all licensed providers to improve patient safety, quality of care, and patient outcomes. In the report, Error is Human, a recommendation was made, or a thought really, that if we could just get providers together and allow them to talk to each other in a protected culture of safety, that we could prevent errors from happening among all provider entities across the country. And one of the things that we're seeing with patient safety organization is a growing transparency among all licensed providers and a great improvement in patient safety. The patient safety organizations can link every aspect of care, from the first moment of care, EMS picking up a patient, through the ER, diagnostic errors,
Important contributions. What do you suggest we do?
Patient safety organizations are fairly new organizations. We're setting up some very innovative programs, peer review and ambulatory care in places that we've never seen peer review actually happen, co-ops throughout critical access hospitals where we haven't been able to reach before. So I'm basically saying that we're new, we're collecting data, we're setting up very innovative programs. We're just starting to get best practices. We're going our association is actually going to be verifying best practices and getting them published. So I'm here to thank the IOM for its many reports recommending patient safety organizations and physicians to allow the transparency to happen among healthcare providers, and that in the future, I think you'll see more of the patient safety organization work, and also being able to work with the government with our best practices and our information, our big data analysis and predictive analytics. So it's just, let's
Thank you very much.
keep these ideas as we move forward.
And what that says is that it goes forward with safety. It wants to recognize those organizations. Please.
Yes, I'm Ben Harder. I oversee the U.S. News and World Report public reporting program. And I think the point that you just made is very relevant and also harkens back to one comment that Farzad made. There are some great measures available in New York and other states, in some systems, and through certain registries that are now publicly reporting, where my group can contribute, and I think Leapfrog and many others, is having an engaged population of patients. Farzad knows to go to CMS and look up the volumes for the procedure he's concerned about, but most patients are going to search online, and if they can't find that information readily in the sites that they recognize and know, they won't actually access that information. So for solving the patient engagement component of improving the dialogue around patient safety, we do need to make sure that that data is available broadly to as many participants in the communication as possible. I think the media are a really big opportunity. My group increasingly is focusing on public reporting, and yet we have some significant obstacles. One of these is that Medicare, while it has made enormous strides in transparency and has more coming, has not made available ambulatory data. So our ability to look at aspects of outpatient care, population health, very, very limited by that. Many states are building all-payer claims data sets, but they're very limited in their resources, and it's unclear whether, in many cases, all of the data will be available for independent analysis by groups like mine, or, for example, Leapfrog or anyone else. And I think these are big opportunities. Health systems, obviously, increasingly, as they grow larger, have their own valuable data sets that could be used in combination with others to develop new insights that patients could engage with on widely known websites like U.S. News. But without that data being available for analysis and for public reporting, we won't have the gains from that.
So what I'm hearing is NAM looking both at the issue of patient engagement and how that can be enhanced, as well as more transparency with regard to
and if I could add
data.
One more comment on Farzad's point, we all know that the data that he referred to on volumes was tied up in a lawsuit for decades.
Yeah, absolutely.
And I think there are legitimate reasons for being concerned about transparency. I get that, and there are patient privacy risks, there are provider privacy risks, but we do have to consider the trade-offs there. I think we can. Most of us, I think, will recognize that is a big win now that data is available. We need to make more big wins like that.
Thank you. I should make disclosure that I'm personally a member of the board of directors of United Health Group, which is a private, both an insurance company and analytic group. And what I've learned is that some of the data that patients want about cost, they would like the doctors to tell them how much things cost. They would like hospitals to tell them how things cost. Neither of them know. Doctors don't know what things are going to cost, nor do hospitals. Because they don't know what services are going to be provided, they don't know what the extent of things are. The people who know are insurance companies, because they're paying all the bills. And so United and now Aetna have programs where you can go on, clients can go on and find out the mean, median, and range of costs for a variety of procedures. And I believe that those belong in doctors' offices, and that although the Blues have problems with data analysis, they could be put under the pressure to provide the same kind of information. So I think patients deserve much more information about cost, and this is an area I think insurance companies can help. Please.
Yeah. Matthew Fitzgerald, Signature Consulting Group. Work for the PQRS as a consultant to CMS. I'm also a public director on the American Board of Ophthalmology. I think our focus on measurement has been misplaced from the perspective that what we really need to be doing is developing tools, strategies, and systematic approaches to care delivery and offering them to busy physicians to facilitate quality improvement. I think for too long we've been measuring, and saying to busy physicians, fix it. I'm very hopeful with that MACRA coming online and with a mandate to medical societies to build registries and a mandate to medical boards to facilitate quality improvement among their diplomats, that this will inspire us to identify these tools, strategies, and systematic approaches to care delivery. So let me make a plea to everybody. Let's use the data to benchmark standards of care, as Betsy Bradley at Yale has done, Harlan Krumholtz for Door to Balloon AMI care, as Dr. Pronovost has done for CLABSI. We really need to focus on strategies for improvement and offer them to our very busy and overworked physicians.
But what I'm hearing is that the sources of that will be the professions themselves. Is that?
I would advocate that, yes.
Yeah, I mean, that's what you're
Yeah,
advocating.
I think the professions are ready to step up, and with the registries that will be built in response, that have been built, that will be built in response to MACRA, I'm very excited that quality data, that top 10% of performers can be identified, and we can ask them what they're doing that makes their care so superlative.
Excellent, thank you. Right, next, over here. Yes, ma'am? Well, why don't we go over here?
You called on me?
Hi, my name's Michael Murray. I'm an investigator at Reagan Streif Institute and professor at Purdue University.
Could you just speak a little louder?
Sure.
For us old folks.
Yeah, Michael Murray, Reagan Streif Institute and Purdue University. I wanted to qualify what I'm about to say by recognizing that there's a lot of patients that need care and don't get it. But if you look at a lot of the reports from IOM, many of them in the discussion today, much of the discussion is about people that enter care and receive care and errors occur. But there's a subset of patients that probably receive care that shouldn't be receiving it. These are individuals that are rummaging around in the pharmacies, at the OTC counters, the herbal supplements, et cetera. And there's, if you look at healthcare as a box, and entering that box is healthcare, inside those boxes are the treatments, diagnostics, surgery, et cetera. Each one of those boxes probably has people entering them that shouldn't be there. And I think we probably need to spend a little bit more time thinking about that and preventing error on the front end instead of waiting to do something after they enter the healthcare box. Some of this could be done through simple things like exercise, diets, et cetera, as well. We're giving drugs to people that need to get out and walk a little bit more, et cetera.
Thank you. Yes, ma'am.
Hi, I'm Leah Binder from the Leapfrog Group. Couple of suggestions quickly. The first concerns culture of safety, and I was fascinated by the many perspectives that came up today. The interesting talk by Matthew about nursing perception of the quality and safety of care. We do know that that is correlated with complications in many respects. I think that it would be very interesting if the National Academy could look at more robust tools or development of more robust tools to measure nursing perceptions, physician perceptions, and certainly from Maureen's talk, especially, I was very galvanized by that, patient perceptions on what can be better in the healthcare system. So I don't think we're good at that. I think we're at the very infancy of figuring out how we bring all these perspectives to the table. But I think that would be a really strong role for the National Academy to help us do. And the second thing I would like to see is building on a culture of transparency in our country. And I think it's time for the healthcare system to lean in to transparency. Back when we did To Err Is Human, as the earlier questioner mentioned, we had protected culture of safety. That was something we talked about a lot. We've set up a lot of structures for protected discussions, meaning protected from patients. We don't hear them. Those are discussions that are done in private. Now, there are contexts in which that's necessary, but we're in a different era now. This is the era of the internet. Expectations by consumers have changed enormously. They expect information at their fingertips. And I think it's going to be important for the healthcare industry to be able to lean into that and find out, when can we be really candid about our performance in a way we've never been before? And how do we do that? I think that also would be an important discussion to follow for the National Academy of Medicine to use to follow up on its pioneering work 15 years ago. And I would suggest one partner for that is the National Patient Safety Foundation, which did an excellent report this year on transparency in healthcare, which was just, I think, very nuanced, talked a lot about how that could happen. I think that would be an interesting partnership as the next generation for this.
Thank you. So this whole area of transparency is expanding and is very relevant. Next, please.
Hi, I'm Ann Greiner from the National Quality Forum. And actually, to follow up on Leah's comment, you know, I think there's like a parallel universe going on with where people are getting their healthcare information, and it's not, you know, from the CMS websites and even really from U.S. News and World Report. You know, I mean, they are crowdsourcing information. David Brailer quotes a statistic that young women who are looking for an OBGYN go to Angie's List, and, you know, that's where they find their doctors. So it would be, I think, really helpful if the IOM would do a systematic study that looks at, you know, where are this generation getting their healthcare information, and what can we learn from that, and how might that inform what we're trying to do with the evidence-based information that we have, and maybe there could be more of a dialogue between these two parallel universes.
Thank you. Clearly, we're just going to take questions from the people who are at the microphones. I'm not going to, the time's running out, so I'm not going to be able to take questions or comments from others. I would say that this particular issue is very important, deserving of study. And one of the issues that the American College of Physicians, among other groups, have looked at is what's the role of the healthcare provider, the physician, the advanced practice nurse, to helping patients find the websites, find the sources to get reputable. It's not that the patients aren't going to go to the web. The question is, can they be directed to go to the web in a way that's constructive and useful? So this whole area is valuable. Please.
Martin Avoitis again. I'm sort of a glass half full person, and I commend the ONC for the Meaningful Use Program, which I think has delivered a set of standards. If anything, that's what we have. Now, I really we are very happy with Stage 3 Meaningful Use. What's coming? The new standards. We think particularly the APIs for the exchange of medical records. My concern is that the Meaningful Use Program might not have enough teeth or enough drivers in its own, like it had once the mass of cash has run out. And I'm not proposing that more cash should be added on the table. I just think that we have to start looking at how the Meaningful Use Program is going to be able to go forward and actually collaborate with Meaningful Use in its objectives, because we think they're very Stage 3 will revolutionize how data will exchange if implemented.
Thank you. That's a very specific suggestion worth taking a look at. Don?
Yeah, Don Detmer, University of Virginia. It's been such a stimulating day. It's going to take me some time to integrate what I've heard, but I think I do have a process suggestion. This has been just, in my view, a highly successful kind of day, and I particularly thank the Rosenthals. But I think the Academy and even the broader Academy structure maybe should think about more of these kinds of days to dialogue with this kind of talent in a smaller kind of setting with an audience listening from afar. There's so many dynamics going on, whether we're talking about how do we move to a social determinants of care, how do we move the precise data analytics to precision medicine, or how do we get information technology to do what we want, and so forth. There's just, I think, it's a time of genuine foment and ferment with a lot to come from this, and so mostly thanks to everybody, but think about doing maybe more of it. Thank you.
Thank you, Don. Last comment?
Thanks. Work on resilience of our workforce. I think that's a very important issue. I think the IOM and National Academy could play a role in that.
And by resilience, this includes the issue of burnout for various health professions, renewal, enthusiasm about their future, things of this sort.
Yep.
Very good. Well, thank you very much. A number of very good suggestions. I'm going to leave Don's last suggestion to our president to address in his final comments. Again, I want to express my personal appreciation to the planning committee that's listed in your brochure. They just did a spectacular job. The 4 moderators that you saw, Carolyn Clancy, Mark Smith, Brent, yes, and Peter Provost, all of whom just did a terrific job with the putting together the panels and moderating them. I think we got some very interesting views from a variety of perspectives, as well as an update. Again, we're grateful to the Rosenthals. And with that, let me express my appreciation to all of you for sitting through this, and all of those who are on the web, and call upon closing comments from our president, Dr. Zhao.